Derek. Now, I hope I don't undo the work you did with the itis with my next exercise, but I am a therapist, so you're getting some free therapy today. Technically not, but you know what I mean. So the first thing that I want you to do is close your eyes. Okay. And I want you to have your feet planted on the ground. And if you can, your hands on your lap. Okay. And now through your nose, I want you to take a deep breath and then exhale slower through your mouth. Very good. Let's do that again. In through your nose, out through your mouth. And then one more time. Very good. Now you can open your eyes, and I want you to hold your hand up. Most of us have 5 fingers, some of us don't, but that's okay. This is a symbolic gesture. It's important to realize that all human beings are built with the DNA for joy. You can put your hands down. And the reason I use your hand is because joy is within our reach, but many of us have forgotten how to access joy. And the mind-body connection that you just demonstrated just now by taking 3 breaths, being grounded, being present, and being intentional allowed you to access joy for a couple of seconds. But we forget about that. Many of us are healthcare professionals in here, and I can't tell my heart to stop beating, right? I can't tell other parts of my body to stop working. I can't tell my liver to stop processing, but I can hold my breath. Why? Because we're made with this powerful tool to control our stress. Yes, it helps with survival, right? If we smell something that's a toxic gas, we have to hold our breath. If we're plunged into water, we have to hold our breath. But also, our breath allows us to calm the fight or flight and to give us a sense of control, even in the midst of chaos. So that very symbolic, powerful gesture is to remind you that the mind-body connection is real, okay? And many of us, over the past couple of years, since 2020, have felt as if we've been in chaos. Yes, things on the outside look like they're normal. We're back to usual. We're open for business. But many of us have not processed trauma. First, the pandemic, we're not safe. Then we are safe. Then there's uprisings. Then there's police brutality. Then there's massive, chaos. There's war. There's climate change. It is like a tidal wave after wave. We can't catch our breaths, right? But if we don't process our trauma, then we cannot ride the wave, right? There's a difference between feeling like we're drowning and riding that wave. So we have to develop tools for this. And it's important for us as healthcare professionals to do this because, we're the healers, but many of us are unhealed. And there's a lot of literature coming out saying that healthcare professionals who are not full of joy, who are depressed, who are burnt out, who are anxious, who are in fight or flight, who are overwhelmed, they make mistakes, important mistakes that cost lives and they cost money. So we need to invest in joy again, not just to save $1, but to save lives. And when we are joyful, right, when we make these decisions for our patients and our communities, when we are joyful, guess what? Joy is contagious. So I asked a question earlier about clinical research. I'm a principal investigator of my own lab in Midtown, very close to here, and I enroll patients all the time. So during the pandemic, we stayed open because we had FDA regulated studies that had to keep going. You got to continue research, even when people are afraid to leave their homes. We find a way, right? And patient after patient I saw who came in, a lot of times they wouldn't meet criteria for depression, but they check all the boxes. But instead of breaking down, they were over-functioning. They were showing up. So they were wearing this mask of productivity. And I started looking into something called high-functioning depression, which, as a board-certified psychiatrist trained at Columbia, fancy institutions, they said, that's not a real thing. As long as you're functioning and you're showing up, you're good to go. So imagine going to your doctor and saying, I I don't feel joy anymore. I'm feeling tired. I can't concentrate. I can't sleep. Food doesn't taste as good. And the doctor's like, well, are you functioning? Yep. All right, I'll see you when you break down. This is a problem. So there's a renaissance happening in medical health today where you see a lot of longevity science. There's a menopause boom. Dr. Alita and I were talking about that. We're really thinking about preventing physical breakdowns, but we're not there with mental health breakdowns. We wait for people to be in crisis to break down before we do anything about it. This is a broken model. So I want to teach everyone in here how to access joy. And guess what? It is free. So you're in for a treat. So you know those 5 things I talked about, your fingers. Think about this. The first part, many of us who are busy, overproductive, thinking about other people, we don't validate when things are going wrong. Someone asks you, how's it going? You know, like today, many of us said, I'm fine, you? Oh, great, yeah. Very rarely will you hear someone say, I am tired. Like, I'm burnt out. I am depressed. You don't hear that. So you don't have to say it out loud, but I want you to, after I count to 3, either say it, whisper it, or think it. I'm going to ask you, how do you feel? 1, 2, 3. How do you feel? I heard a couple of things. Tired, great, stressed, right? You can validate both positive and negative emotions. It doesn't always have to be negative, right? And the reason that you want to validate how you feel is because it's evidence-based. There's something called affect labeling. Human beings do not like uncertainty. We need to know what's going on. So when you don't know how you feel, you're stressed. That's why people go to therapy, so that you can talk to people so that they can identify how they feel so they are less stressed. Number 2 is venting. All right, so you just all vented. You let out the steam. You talked about what you were feeling inside. People are not comfortable talking all the time. Some people like to pray. Some people like to cry. Crying recently has been like a really good one for me. Like, I'm stressed, I cry a little bit, I feel better, right? There's nothing wrong with expressing these things. Some of my artists that I treat like to sing or paint, just express it in a way that feels authentic to you, but get it out. The third is values. Now, values are things that are priceless, that don't have price tags, but we often chase the things with the price tags. But think about the things that mean the most to you in life, like your faith, the causes you believe in, like your community. That's why we're all here. Our families. These are where we should be pouring a little investment daily. It doesn't have to be a lot, but when you pour into your values, the priceless things, not the price tags, the research shows us that makes you happier. And the fourth is vitals. We talked heavily about vitals today, right? We talked about getting good sleep, getting good movement, eating foods that are not processed. But the other vital that we haven't really discussed is our relationship with technology. And I'm guilty of this too, right? But we have to understand the ways that not being able to break off from work and technology impacts us. And the number 1 predictor of longevity is our relationships. So you can eat all the kale you want, but if you're with someone toxic, it's going to drain your life source. So let's think about that too. And the 5th V is vision. How do we plan our joys? How do we celebrate our wins? In my lab, whenever we pass a training, Danielle knows this, like when you do clinical research, you do training after training, it just becomes numb to you. We celebrate each training, we print it, we put it in a binder, and we say, this is what we did, right? Celebrate the small wins. So if you got your kid to school on time, like I did this morning, I celebrate that because it's hard. Sometimes it's hard, right? Plan joy. The way that we plan out our schedules, make time for joy. So it is within your reach. It is in your DNA. You just have to learn how to access it sometimes, because in this day and age, bad news after bad news, exposure to news all the time, it's hard to access joy. We experience something called anhedonia, which is a lack of feeling pleasure and interest in things that used to once light us up. And the way to combat it is to recognize it, right? So if you feel anhedonia today, I'm feeling a little anhedonic today. I need to do something. I need to access my joy. Let me tap into these 5 V's, one of them. You don't have to do all at once, just one, right? Well, thank you. I hope that I woke you up a little and relaxed you a bit. Yes. Oh, thank you. Thank you. I actually have a video coming out because I do content, and it's about vitamin J, the deficiency in joy. So I'll tag you in it. All right, thank you so much.
Thank you so much. Thank you. All right, without further ado, I'd like to continue on. We are once again going back to one of our previous panels that we didn't do. We're doing Beyond the Discount, 340B, and the Black Health Justice. So could we have all of our panelists come on for Beyond the Discount, 340B, and Black Health Justice?
Good afternoon, my beautiful, brilliant people. We have finally made it to the other side of lunchtime. And as we heard our good friend Derek give us a sermon on the itis, please stay tuned. And also, the breathing technique was amazing. I'm Ebony JJ Curry, senior reporter for Michigan Chronicle. We are a publication, and we are under the umbrella of Real Times Media, who's a Black-owned publication who has several companies throughout the country. And I am excited to dive into this conversation of 340B. Today, we're diving into the 340B program, but more importantly, we're here to discuss what these policies mean for our communities. The 340B program was designed to help underserved populations by providing discounted medications to hospitals and clinics. However, without proper transparency and accountability, the benefits of this program may not be reaching the communities it was intended to serve, particularly the Black and Brown communities. I'm excited to have an honest, thought-provoking conversation that leads to actionable steps. So with that, I want to go ahead and have our panelists introduce yourselves. If we can have you start with introducing yourself quickly and tell me, why is it important for you to be here today?
So good afternoon, everyone. My name is Pamela Price. I am the Deputy Director of the Balm in Gilead. I want to thank BDO and your amazing sponsors and USA Today for hosting some really important conversations that we need to have not only in this room, but also thinking about how to take these back out to our communities. When I think about the why I'm here today, or just about the why that I do the work that I do, it all harkens back to my grandparents. It harkens back to my roots and my lineages. Specifically for this conversation today, I think about my grandparents and watching them sit around the kitchen table and go through which medications they were going to get and which medications they were going to forego for a month, 2 months, 3 months. I think about how they were going to put a cable bill in my name when I was 8 years old. I think about the equity things that we have, and we put health as an umbrella over that, but really our why, when we think about health equity, it's about the human aspect of it. We can't have healthy human beings if they aren't economically sufficient, if they aren't educationally efficient. There's all these different buckets and dimensions, and even just what we came out of this exercise of joy and our mental health and our mental well-being, we never connect all those dots together in an equitable lens. And so that is kind of my why and what I hope to delve into today.
And I'm Thomas Johnson. I'm Executive Director of ASAP 340B, and we're a coalition of about 26 different organizations that are seeking reforms in the nation's 340B program. Why I'm here, other than I was asked by BlackDoctor.org to come here, I've spent the majority of my career working for organizations or volunteering and helping organizations that have a special focus on the Black and other minority populations. I also currently serve as the chair of the board of the Sickle Cell Disease Association of America. I ran an organization for 9 years called the Medicaid Health Plans of America. I ran the DC Hospital Association, and I worked for other interests that have a specific focus on the Medicaid population. So, I'm really happy to come full circle with this particular issue to talk about how this affects Black people and expose some of the things that have been happening with this particular program. We are not getting our money's worth with regards to the spend that's taking place in this program. And that's something that should happen, especially when the program is supposed to be aimed at helping those covered entities that have scarce resources to purchase prescription drugs for the underserved population that they serve.
I think it's very important for us to stay right there. The fact that the 340B program is specifically designed for underserved communities. And today we're having, for a while, we're having issues with transparency and accountability. For you both, starting with Pam, why is 340B so contested still today here in 2025?
I think in large part because in this country, healthcare is both transactional and a capitalistic venture. No one is in the healthcare business for the most part because they want to save lives, because they want to prevent disease and or prevent illnesses. The reality is that most of it is an ROI is the dollar. How much is this going to cost? How much will I make? And when you have a program like 340B, who its inception and its intent is just that. How do we help make not only affordable medications accessible to the communities that are most vulnerable and are in most need, but how do we also then use those dollars from those savings to access treatments, behavioral health, opiate use, right? And so when you have a program like that, that now is a part of a broken healthcare infrastructure, it's really hard to maintain that type of fidelity within a program. And then it becomes fractured because it starts out as a federal program. And then when you start to scale and expand, and now we have large hospitals who are also benefiting from the cost savings, but then the reinvestment that is supposed to happen does not happen. And there's not oversight, there's not enough oversight rather. And then what you have in the cracks of it, we started the day out talking about the business case of health equity, right? What we end up having is that our communities are caught in this crosshair between what we're going to pay, what we're not going to, cover. And as a result of that, ultimately, our communities end up having in some shape, fashion, or form, pick up the slack. And by picking up the slack, that is sometimes death. Sometimes it's the poor health outcomes that our communities have because we're not building these programs in a way that centers the community to begin with.
I'm going to answer a little different way, and this is probably a Washington answer. When you have a statute like this that creates a program, there are very smart people that work for hospitals and other types of entities that figure out not only what the law says, but also what the law does not say. And so this program that is over 30 years old has guidelines for what it's supposed to happen with covered entities. But there are a lot of areas that are silent. And so what's happened is certain entities, and I will say it's mostly hospital systems, has figured out how to game this program so that they can make it now a profit center instead of a program that's supposed to get them drugs at a discount. And you can imagine if you're able to get your drug at a 50% discount, which is a serious discount for a prescription drug. And the law allows you to, because it's silent, to resell that same drug for 500% to 1,000% of the same cost. You are now gaming the system. And the law allows you to do that because it's silent, because it doesn't say anything or prevent anyone from doing that. Why do we know this is happening? Because national outlets have talked about it and talked about how the system and how this program is being gamed. So there are interests in Washington that don't want things to change because in healthcare, as you talked about, because it's largely, well, there's a large percentage of for-profit entities that are in the system. They want to profit in those areas that they can profit from. And so they figured out how to profit from this program.
Absolutely. I believe, those loopholes is what causes a deeper conversation, hence where's the transparency and accountability. I can recall a New York Times investigation found that Bond Secures diverted 340B revenue from a hospital in a low-income neighborhood to fund facilities in wealthier suburbs. So it kind of just pulls me to the point of, how do the current gaps in 340B accountability translate into consequences for Black patients in those underserved communities?
I'll speak to that. And in addition to what you pointed out regarding Bond Secures, not only were those child sites set up in wealthier communities, but a couple of other things take place. One, they end up reducing capacity in the underserved areas. So there's a trade-off. Bond Secures actually reduced capacity in the underserved area that it's located in and expanded in those wealthier areas. And we've seen that in other hospital systems as well. The other thing that happens is that because they are now using this program in those wealthier areas and charging Medicare, Medicaid, and the private sector 500 to 1,000% in some cases for these drugs. Now, instead of that Medicaid drug costing, let's say, $100 for a person, is now costing 500 to 1,000. Wow. So instead of serving 5 people for that drug, you're serving 1. Or instead of serving 10 people, you are serving 1. So that creates inequity with regards to how those Medicaid dollars are being spent for prescription drugs. And that disproportionately harms people that are on public programs.
So Bon Secours is in our backyard. So we actually saw that. I know exactly where that campus is because it's in Northside Richmond. Northside Richmond is, again, it's one of the most impoverished, underdeveloped, under-resourced neighborhoods within Richmond. And in addition to everything that Thomas just said in terms of how it reduced services that were available at that Northside hospital that was there and the communities that could come. And I'm talking about everything from emergency services, which the individuals in that community used heavily, the ER in that at that hospital. But what it also did is it causes a redirection of some of the federally qualified health centers who also have access to the same program. However, because theirs is coming typically in the form of a grant or federal recipient, there's not so much mismanagement of that fund. They know that that is a requirement for you to actually receive the savings and benefits that you're getting. So like, for example, even now thinking about the climate and things that we're in, Virginia has about 30-ish or so federally qualified health centers and or community health centers that rely heavily on a 340B that operates the way that it's supposed to, and a federal government and policies that operate the way that they're supposed to. About 16 of those have had to either close and or reduce their services. Meanwhile, the larger health systems have not. That particular year that that report came out, Bon Secours netted $8+ billion in revenue. Meanwhile, if you ride through Northside Richmond, past that hospital on North 25th Street, like we do, you see rampant homelessness, unemployment. The life expectancy within that zip code is about a 10-year lower than its neighboring zip codes. And so it's catastrophic when you don't have the right policies and the right infrastructure, both at state and at the federal level.
You know, I want to stick on the community standpoint of it all, because at the end of the day, it's the community who are being impacted by the lack of transparency and accountability within this program. Can we identify, and I really want to dig deep here, can we identify stories or examples where the failure to reinvest 340B savings has directly harmed Black communities?
I'm going to give you some examples of how redirection of funds from this program has avoided taking care of Black communities. You know, this is my third year involved with this effort. And the first group I spoke to was a group of African-American ministers in New Jersey. And one of the first things I mentioned with regards to this program, because a lot of people have not even heard of this program. Okay, this is the second largest drug discount program in the country. 120 billion plus spent on this program in 2023. Okay. There was one system that used the money from this program to pay for the salary of their football coach.
Wow.
Fountains have been paid for. Expansion for a facility in Beverly Hills has been talked about. These are things that are not directed at our community. But because the way the law is written, there is no requirement for hospitals to reinvest this money into those facilities, like there are requirements for clinics to reinvest that money in their facilities. So again, when I talk about, you know, gaming the system, you look at what the law says and what the law does not say. And that's an example of money being redirected from those underserved areas to, in some cases, areas that don't even pertain to healthcare.
Wow.
Exactly. You know, it's interesting because I think, yeah, the fact that this is such a large program and how little the communities who it is actually supposed to help know about it. We did just a flash survey in preparation for me coming to here today of roughly about 500 people. Only barely 20% had ever heard of 340B. But based on their zip code and some other information we calculated, they are within areas, and you know, so we can make that they are seeking services at these covered entities. Yet they don't know that this program exists. We found in cases where people don't even know you are being used. Your MRN, your medical record number, is associated with a discount that this hospital has and or is receiving. And yet and still you can't look around your community and see how it is coming back to you. We've also seen where even within the Bon Secours situation, where people are getting debt notifications. So that's another issue, because again, there is nothing that is prohibiting you. You've benefited, you've marked up the cost of this drug, you've benefited because I'm allowing you to be able to access this benefit and you have it, but I am also now getting a medical debt notification. And that's impacting, again, economically the patient. So now you're talking about economically, our communities are being impacted. They're already being disproportionately impacted by just the health outcomes in general. And it just becomes a layer upon layer upon layer when you think about how broke the system is, because you have one tier that has requirements and expectations and what you must do. And you have a significant chunk who does not have that, but they are probably more in position to actually make those types of reinvestments than a small clinic or a safety net clinic. And then we've seen nationally the number of safety net hospitals, especially in our rural communities, close, not limit services, they are closed. You're talking about folks who are having to drive 2 and 3 hours to get to a primary care physician, let alone a specialist. Even emergency trauma 1 centers where a safety net could hold a position, stabilize a patient, that is gone. So now I have something life-threatening and there's nothing in my proximity that is going to allow me to at least stabilize my patient or my, my loved one until we can get to a higher tier of care. And so it's like one of, we like to think of things as circular, right? This is not a linear thing. It's not a horizontal, vertical thing. This is all circular. So if we are making sure that everyone who's connected to this ecosystem is adhering to the same types of requirements and regulations that benefit, again, it trickles, I hate to say trickle down, but or trickles around rather, so that the communities are actually being able to benefit from the program the way that it was designed or meant to.
I think it's very vital when it comes to this particular subject 340B program that we educate everyone on what 340B program is, also touch on why there is an issue, but what's most important is how can we fix what has been broken. So question, I would love for Thomas to start this off. As you mentioned, the loopholes that's going on, what immediate actions can hospitals or even lawmakers can take to ensure that 340B savings are redirected towards closing the health gaps in these Black communities that we're talking about today?
Well, I think first and foremost, transparency is key. And I think that all covered entities in this program need to have the same transparency requirements. And I think the clinics are a very good example of the type of transparency that should be applied to every covered entity in the program. So you can see what's being reinvested. You can actually see the spend that's created under the program. You can see the population that's being treated under the program. Because right now, the way the program is set up, there's no real connection between the patient and the covered entity. If I go into a hospital, I don't know that the hospital is using the 340B discount for me. And I certainly don't know how much money they have resold this drug for and made a profit off of treating me. So I think transparency is the key. I think it's you have a very, very hard time saying with $120 billion being spent that there should not be transparency in this program. That's really the key, I think, to a lot of these issues so that the public is aware of this program. Because without transparency, and it doesn't exist now the way it should, nobody really knows about it.
I think earlier, we touched on who having the right people at the table, right? This 340B is like many federal state programs that we have, and even industry that's in this room. We build and we get too far down the train tracks before we have even considered bringing patients and the community to the table and to the conversation. And I think now with the lens that we have on 340B, this is, like we said, we have some crisis opportunities right now, because there's crisis, but there's also some opportunity in the midst of it. And this is one of those opportunities to where large health systems should have more community linkages and or community associations and connections to who they are serving at the patient level and at the provider level. So all of that is working in conjunction and in tandem with each other. Because what we have now is that you have one side who wants to control the narrative that 340B is going to end up being more costly and it's going to hurt more individuals. And that's not the case. So it's really thinking about how are we going to craft these narratives, and the only way that you can craft the narrative for a program that was designed for underserved communities is to actually get those underserved communities to the table, hear their concerns, make them aware of what this program is, how it's supposed to operate, and then get them to push from the grassroots, from the community level to our legislators. We talked about the power we have laid it down time and time again in terms of making sure that whoever we send to Washington, whether we voted for them or not, but that they are supporting the issues and things that matter to us, that we are letting them know where we want for 340B to go. We don't want it to move forward like it is. Here's our suggestions on how to reform this and make it better and make it serve us the way that it needs. And the only way that that's going to happen is by making sure that we get community voices and more community voices at the table. And like those of us in this room using our platforms and our organizations to bring that to the attention.
I just want to underscore something because, you know, I hear this constantly, and I also, and I have to refute it whenever it comes up. Our coalition is in support of the 340B program. We make that very clear. And our coalition is led by two main groups, National Association of Community Health Centers and PhRMA. Now, as you can imagine, it's hard to get those two groups to agree on just about anything. But the concerns that both groups have about what's been happening in this program, where 87% of the dollars go to hospital systems. The concerns were so great, and the silence from the hospital community was so strong that the community health center said, okay, well, if you're not going to talk about this, let's talk to PhRMA. That's how big the concern is. We're glad blackdoctor.org is now part of our coalition, as well as the other groups that make up the 26 groups that are members of ASAP 340B. And I brought some material that's out at the desk outside if you want to learn more about our coalition.
You know, I think it's quite evident from the conversation we've had today that we'll be risking some things if we continue with the status quo. And I'm curious, how might this deepen existing health crisis in the Black community? I know we're short on time, but I really want to take a deeper dive into the resolve. So again, how might, if we continue with the status quo, how might this deepen the crisis here in the Black community?
I think one thing that there's real concern about is because there is such an incentive for hospital systems to game this program in the way they've been doing it, especially in the area of oncology, okay? This is putting great pressure among individual practitioners, and it's creating a very strong climate of vertical integration where hospitals are acquiring individual practices, especially in that space. Now, we're hearing this from the oncologists. There are two different oncology groups that are members of our coalition, and they point out very, very clearly how this ends up creating less of an environment for oncologists to succeed in individual practices for cancer, which is a leading cause of death in our community. So that is one specific area where this pressure and this vertical integration is taking place that does have an effect on our community.
I think it's also impacting us when we think about innovation and just the advancement in healthcare as well. Like again, at the end of the day, we are talking about a significant amount of money. And if we think about it being properly reinvested the way that it's supposed to, now we're also looking at how it will impact Medicaid and or Medicare and other populations. How is it going to have an impact on, you know, that working individual who has some type of insurance, but it's not full insurance? So there's a ripple effect when we have something this broken in terms of 340B. When we have, you know, hospital pharmacists who again are having to adhere to certain standards in terms of how they are, you know, costing medications and drugs and what drugs they're even making available, right? We've seen restrictions in specialty medications. Well, we know that's about half of the prescriptions that we give out in this country. So if half of those are now being restricted from this program that these communities need that would include cancer, a lot of our cancer medications, that is going to have a significant impact on our communities as well, because now we may have completely taken drugs that were once available to you that now completely won't be available to you.
And I want to wrap this up with asking in a very simple sentence regarding the resolve, what type of measurement tools should be created in an ideal world when it comes to 340B and transparency and accountability?
I think coalitions, like what Thomas is doing, I think coalitions are just a great way to get the right people to the table, because it really is going to take a concerted effort. Everyone is going to have some skin in this game. We're talking about beyond the discount. This has got to be more than a 5-finger type of discount, which is what is going on right now because we're stealing money in essence. So we have to make sure that everyone, pharma, hospitals, your community health centers, everyone is saying, hey, this is the role that I can contribute. Here is where I feel like we are best suited to guide and drive this particular aspect of the program. We can help oversee and provide insight onto that. So it really, for me, I think about it's going to take a village. I think, and also because we're a faith-based organization, the scripture asks us, God wants us to ask us to what you do for the least you do for me. So if we build and create that way, then we won't miss anyone.
I would say, excuse me, as I spoke before, we need to have a consistent standard as it relates to transparency. And if the hospital systems were to adopt the same transparency measures that the clinics have, that would be a huge step towards getting the type of measures that I think you're asking about. And amazingly, at a hearing 2 years ago about this, there were arguments being made that hospital systems could not adopt those. Okay, these multi-million-dollar hospital systems could not do the same thing that a $2 or $3 or $4 million clinic is doing.
Yeah.
Okay, that does not pass the smell test to me.
Yeah. We have about 30 states with 340B hearings, and blackdoctor.org plans to support community voices throughout those 30 states. I would like to leave you guys with this. This isn't solely about policy. It's about justice. It's about survival and the right to equitable health care. Simple as that. The absence of transparency in the 340B program disproportionately harms Black communities, allowing institutions to benefit without delivering on their promises. Healthcare disparities won't change unless we demand systemic accountability. Thank you to our amazing panelists. Thank you to blackdoctor.org for this amazing conversation. And you guys take care and enjoy the rest of your day. Thank you.